Welcome to the Hospital Medicine Unplugged podcast. Today we're tackling a really high-stakes area in hospital medicine, especially in critical care, thyrotoxicosis, and its most extreme form, thyroid storm.
Yeah, this is definitely one of those endocrine emergencies that demands our full attention. It's thankfully not super common, but the mortality rates associated with thyroid storm are frankly alarming.
Exactly. Sources quote anywhere from, 3.6% up to even 25%. That's a huge range, but even the lower end is concerning.
It really is, and that higher end, that 25%, often reflects delays in diagnosis or, initiation of the right treatment. The window to act effectively is just incredibly narrow when a patient presents this sick.
So our goal today, our mission, if you will, is to really drill down into the evidence-based strategies. We want to focus on how to rapidly diagnose, crucially differentiate the underlying cause, and then launch that immediate multimodal therapy needed for these critically ill hospitalized patients.
And that brings us right to probably the biggest challenge we face on the floor or in the ICU, the diagnostic mimicry.
Right. That classic triad, the high fever, the really fast heart rate, the altered mental status. It looks like so many other critical conditions.
Severe sepsis, absolutely. Or maybe sympathomimetic toxicity, like a cocaine overdose. Even things like serotonin syndrome can present similarly. You can't just wait for the labs to come back definitively confirming thyroid storm. Clinical judgment has to drive the initial actions.
Okay, let's start by getting the terminology straight. It's actually quite important here because it guides how we think about treatment. We need to separate the overall clinical picture from the specific cause.
Good point. So, broadest term first, thyrotoxicosis. This just means the signs and symptoms you get from having too much thyroid hormone, T4 and T3, floating around. Doesn't matter why it's high.
Could be the gland making too much. Could be the gland leaking hormone because it's inflamed. Or, someone could even be taking too much thyroid medication.
Exactly. It's just the physiological state. Then we narrow it down to hyperthyroidism. This specifically means the thyroid gland itself is overactive. It's synthesizing and secreting too much hormone.
That's your classic Graves' disease or maybe a toxic multinodular goiter. The factory is genuinely in overdrive.
Right. And then the most severe end of the spectrum, thyroid storm. This isn't just bad thyrotoxicosis, it's a life-threatening emergency where the body's systems are decompensating. You've got multi-organ failure driven by that massive thyroid hormone effect.
And this always requires aggressive, immediate intervention, usually in the ICU.
Almost invariably, yes. ICU-level care is pretty much mandatory.
So when we say multi-organ dysfunction in storm, what are we really looking for? The heart usually screams first, right?
Oh, absolutely. The cardiovascular system is under immense stress. You see profound tachycardia, rates consistently over 130 beats per minute, often higher.
And difficult to control sometimes.
Very difficult. Plus, new arrhythmias pop up. Atrial fibrillation is incredibly common. And then there's heart failure, often this high-output heart failure that can just plummet into cardiogenic shock if you're not careful. Metabolic demand is just overwhelming the pump.
Okay, heart struggling. What else? Temperature.
Yep. Thermal regulation goes haywire. Significant hyperpyrexia fevers, often over 38.5 degrees Celsius, sometimes much higher. But, if you had to pick one thing that really signals storm versus just severe thyrotoxicosis,
Gotta be the brain.
it's the brain, the neuropsychiatric dysfunction. Agitation, confusion, outright delirium, psychosis, even progressing to stupor or coma. That CNS involvement is the real hallmark.
And the literature is pretty clear that CNS dysfunction is a major red flag, right? It points to a much higher mortality risk.
Significantly higher. It tells you the system is truly overwhelmed, that the compensatory mechanisms have failed.
We also see other systems involved, maybe less specifically. GI symptoms, liver.
Sure. Nausea, vomiting, diarrhea, abdominal pain are common. And you often see liver enzyme elevations, maybe even jaundice, reflecting that sort of systemic metabolic chaos, and sometimes even direct hepatic injury or dysfunction related to heart failure.
So we have the sick patient, looks like sepsis maybe, but storm is high on the differential. How do we actually make the call? We said labs alone aren't enough.
Correct. The diagnosis is fundamentally clinical. We use scoring systems to help standardize things and, frankly, to push us towards aggressive treatment when needed. The classic one is the Birch-Wartowski point scale, the BWPS.
And the beauty of the BWPS is how it weights the clinical signs, especially the non-thyroid ones.
Exactly. It looks at the temperature, the degree of CNS dysfunction, how fast the heart rate is there AFib, is there heart failure, and are there known precipitating factors? It gives points for each.
And a score of 45 or more is considered highly suggestive of storm.
That's the threshold, yes. 45 or higher basically means treat as storm until proven otherwise. And importantly, severe CNS dysfunction alone can get you a significant number of points, really highlighting its importance.
There's also the Japanese Thyroid Association criteria, the JTA criteria, right? Using TS1 and TS2 categories?
Yes, developed primarily for Asian populations, but also useful. It similarly emphasizes that multi-organ failure, especially CNS changes, is key to defining storm, not just the absolute T4 level.
The point is, these tools help us recognize the severity and act, moving past diagnostic paralysis.
Precisely. Once that score hits the threshold, you shift gears from purely diagnostic workup to immediate therapeutic intervention.
Okay, so what usually tips someone over the edge? What triggers this decompensation in someone who might have had, say, stable Graves for years?
In the hospital, you absolutely have to hunt for triggers. Underlying disease is often Graves or a toxic nodular goiter, sure, but the trigger is usually some kind of acute stress.
Like surgery, infection.
Exactly. Recent surgery is a big one. Any significant infection sepsis, pneumonia is common, major trauma, sometimes medical procedures like receiving iodinated contrast die.
And a really common one we see abruptly stopping their anti-thyroid drugs.
Oh, absolutely critical to ask about medication adherence. Stopping PTU or methimazole suddenly can definitely precipitate storm. We need to screen for all these possibilities.
All right, so we suspect storm, we're starting supportive care. Now, the diagnostic focus sharpens. We need to confirm thyrotoxicosis, yes, but more critically, figure out why it's happening. Etiology dictates therapy.
This is the absolute pivot point, because treatment is fundamentally different depending on whether the thyroid is overproducing hormone or just leaching stored hormone.
The initial labs are usually straightforward for confirming thyrotoxicosis itself.
Right. TSH will be suppressed, usually undetectable, unless it's one of those super rare TSH-secreting pituitary tumors.
Oh.
And free T4 and T3 will be elevated.
You mentioned T3. Our sources often talk about checking total T3, sometimes even favoring it over free T3, especially in sick patients. Why is that?
Yes, that's a really important lab nuance. The issue is with the free T3 assays, particularly the common analog immunoassays. They're just not very reliable in critically ill patients.
Why not?
Well, things like alterations in thyroid hormone binding proteins like TBG, which are common in critical illness or euthyroid 6 syndrome, can really mess up the measurement. Low protein levels, certain drugs, they interfere. So the free T3 could be falsely low or even falsely high.
So total T3, while maybe also affected somewhat, might give a better overall sense of the hormone load.
Often, yes. It seems to be a bit more robust in reflecting the true severity of the thyrotoxic state in these very complex, sick patients. It's worth considering ordering both, but don't be falsely reassured by a normal free T3 if the clinical picture screams thyrotoxicosis.
Okay, so high T4, T3, low TSH confirms the state. But how did it get high? Synthesis versus destructive, that's the key question.
That is the therapeutic crossroads. If it's synthesis, the factory is working overtime, like in Graves' toxic multinodular goiter, or amiodarone-induced thyrotoxicosis. Type 1, you need thionamides like methimazole or PTU to block production.
But if it's a destructive release, the gland is inflamed or damaged, leaking stored hormone like in thyroiditis, subacute, painless, drug-induced like from lithium or checkpoint inhibitors or AIT type 2, then thionamides are basically useless.
Correct. There's no significant ongoing synthesis to block. The treatment there shifts to managing the inflammation, usually with steroids and supportive care. And we also need to consider exogenous intake, someone taking too much thyroid hormone pills. Checking a thyroglobulin level can help there. It should be low if it's exogenous intake.
So in the acute setting, how do we make this crucial distinction quickly?
If you suspect Graves's, which is the most common cause overall, the go-to test is the thyrotropin receptor antibody, or TRAb. It's very sensitive and specific. If TRAb is positive, you've confirmed Graves, and you know synthesis blockers are needed.
What if TRAb is negative, or the picture isn't clear? Maybe you suspect nodules or thyroiditis, or specifically amiodarone toxicity.
Then imaging becomes key. The gold standard historically is thyroid scintigraphy, the radioactive iodine uptake scan, RAIU, or a technetium scan. The pattern tells the story.
How so?
Graves' shows diffuse, high uptake across the whole gland. Toxic nodules show hot spots of high uptake just in the nodules. But critically, destructive thyroiditis or exogenous hormone use shows low or absent uptake. The gland isn't actively taking up iodine because it's either damaged or suppressed. Low uptake means it's a release problem, not a synthesis problem.
But uptake scans take time. right? And they're often contraindicated pregnancy, recent iodine contrast.
Exactly. They're often impractical in the acute setting for critically ill patients, which is why thyroid ultrasound with color Doppler performed at the bedside using POCUS is becoming so incredibly valuable.
How does the ultrasound help differentiate?
It's about vascularity, the blood flow. A hyperactive gland like in Graves', or AIT type 1, will show absolutely avoid aspirin and other NSAIDs. This is a critical point. Aspirin displaces T4 from its binding protein, TBG. That increases the free biologically active T4 level, potentially making the storm worse. Stick with acetaminophen and physical cooling methods.
Good reminder. Plus, aggressive volume resuscitation, nutritional support if needed, and treating any underlying trigger, concurrently antibiotics for sepsis, etc.
Right. Then we deploy the 4 pharmacologic pillars, and the order matters, particularly for the first 2.
Pillar 1, reduce hormone synthesis, shut down the factory, use a thionamide. Historically, PTU was often preferred for storm.
Yeah, propylthiouracil, PTU.
Yeah.
The thinking was twofold. It blocks hormone synthesis within the gland, but it also has a peripheral effect. It inhibits the conversion of T4 to the more potent T3 in the body tissues.
And the dosing reflects the urgency. A big loading dose,
Right.
500 to 1,000 milligrams, then 250 milligrams every 4 hours.
It's an aggressive dose. However, we need to talk about methimazole. PTU carries that black box warning for severe liver injury, which is a real concern, especially with high doses. Methimazole also blocks synthesis very effectively, just without that peripheral T4 to T3 blocking effect.
And this is where newer data comes in, right? Comparative effectiveness studies.
Exactly. Several fairly large retrospective studies, including one in JAMA Network Open a few years back, have looked at critically ill patients with thyroid storm treated with either PTU or methimazole, and they found no significant difference in mortality or major adverse events between the 2 drugs.
That's really important clinical information.
It is. It suggests that the theoretical peripheral benefit of PTU might not translate into a real-world survival advantage in storm, and it means we can feel more comfortable using methimazole, especially if there's any concern about liver function or if it's simply more readily available.
So methimazole at a dose like 60 to 80 milligrams daily, usually divided, is a perfectly acceptable, maybe even preferable first-line choice for many patients now.
I think that's a fair summary of the current thinking, yes. The key is starting a thionamide immediately to block synthesis.
Okay, pillar 2, block hormone release. Stop the leak of preformed hormone using inorganic iodide.
Right. We use things like SSKI, saturated solution of potassium iodide, or Lugol solution. SSDI is usually 5 drops orally every 6 hours. Lugols maybe 8 to 10 drops every 8 hours.
Now, the critical timing point. This cannot be stressed enough.
Absolutely non-negotiable. Iodide must be given at least 1 hour after the first dose of the thionamide, PTU, or methimazole.
Why is that delay so critical?
Because if you give a big load of iodine before you've blocked synthesis, the overactive thyroid gland will greedily snatch up that iodine and use it as fuel to make even more thyroid hormone. That's the Jod-Basedow phenomenon, iodine-induced hyperthyroidism. You make things worse.
So, block the factory first with the thionamide, wait an hour for it to start working, then give the iodide. The iodide then works via the Wolff-Chaikoff effect, temporarily shutting down hormone release.
Precisely. Block synthesis, then block release. Wait that hour.
Pillar 3, peripheral conversion blockade and adrenal support with glucocorticoids.
Steroids do 2 key things here. First, they do inhibit the peripheral conversion of T4 to T3, adding another layer of reducing active hormone levels.
And second,
and arguably just as important in these incredibly stressed patients, they treat potential relative adrenal insufficiency. Critical illness puts huge demands on the adrenal axis, and providing stress dose steroids is often crucial.
standard options are hydrocortisone or dexamethasone.
Yep. Hydrocortisone 100 milligrams IV every 8 hours is common, or dexamethasone 2 milligrams IV every 6 hours. Dexamethasone might have a slight edge in blocking T4 to T3 conversion, but either is generally fine.
And finally, pillar 4, adrenergic control. Taming the sympathetic overdrive symptoms with beta blockers. This is often the first thing given in the ED.
Usually, yes. And propranolol is the classic choice. It's non-selective, so it helps with the tachycardia, the tremor, the anxiety. But importantly, at the high doses used in STORM, propranolol also inhibits peripheral T4 to T3 conversion.
So it's not just symptomatic treatment, it's actually part of the core therapy.
Correct. Dosing can be IV initially in a crisis, maybe 1 to 2 milligrams slow IV push every 10 minutes or so, carefully monitoring hemodynamics. Then transition to oral, maybe 60 to 80 milligrams every 4 to 6 hours.
What's the main caution with propranolol?
Decompensated heart failure. If the patient has severe systolic dysfunction and is already in cardiogenic shock, a non-selective beta blocker could theoretically worsen cardiac output.
So alternatives in that specific situation.
You could consider a cardioselective agent like esmolol, which is a short-acting IV infusion, allowing for quick titration. Or, particularly if AFib is the main issue, a non-dihydropyridine calcium channel blocker like diltiazem can be used for rate control if beta blockers are truly contraindicated.
Good. And what about adjuncts? Anything else we can add if the standard 4 pillars aren't working fast enough?
Yes, cholestyramine. It's a bile acid sequestrant, 4 grams orally, maybe every 6 to 8 hours.
How does that help?
It binds thyroid hormone in the gut, interrupting the enterohepatic recirculation pathway. This basically helps pull more hormone out of the system and speeds up clearance. It can be a useful add-on in refractory cases.
Okay, let's talk about a really common and tricky scenario, amiodarone-induced thyrotoxicosis, or AIT. This drug is loaded with iodine and frequently causes thyroid problems in cardiac patients.
AIT is a major challenge because, as we alluded to, it comes in 2 main flavors with opposite treatments. Getting the diagnosis right is paramount.
Let's recap the types. Type 1 AIT.
Type 1 is basically iodine-fueled synthesis. The patient usually has some underlying thyroid autonomy, maybe undiagnosed graves or nodules. The huge iodine load from amiodarone provides substrate for the gland to go wild and overproduce hormone.
So treatment for type 1 is?
High-dose thionamides, usually methimazole, often needing 30, 40, even 60 milligrams a day, sometimes for a long time, to shut down that synthesis.
Okay, and type 2 AIT?
Type 2 is destructive thyroiditis. Amiodarone itself is directly toxic to the thyroid cells. It damages them, causing them to rupture and spill large amounts of preformed hormone into the circulation. There's no real increase in synthesis.
So treatment for type 2 is?
Inflammation control. Glucocorticoids are the mainstay. High-dose prednisone, maybe 40 to 60 milligrams a day to start, then a very slow taper over typically 2 to 3 months as the inflammation resolves. Thionamides don't help here.
So again, differentiating is key. We mentioned Doppler ultrasound being helpful.
Hugely helpful, especially since uptake scans are often useless due to the iodine load from amio. Doppler shows blood flow. Type 1 synthesis, high vascularity. Type 2 destructive, low vascularity. Making that call quickly means starting the right drug, methimazole or steroids, sooner.
And sometimes it's mixed, right?
Absolutely. Mixed forms exist where there's both some underlying synthesis and destruction. Those cases are tough and might require both thionamides and steroids initially.
What about stopping the amiodarone? That's always a big discussion with cardiology.
It's very controversial and absolutely requires a multidisciplinary discussion. Amiodarone is often keeping a dangerous arrhythmia suppressed. Stopping it could be more dangerous than the thyrotoxicosis itself, especially in type 2 AIT, which should resolve with steroids anyway.
So the decision is highly individualized.
Completely. Often, especially with type 2, amiodarone can be continued while the thyroiditis is treated with steroids. You treat the thyroid issue, then reassess the long-term need for amiodarone with the cardiology team. Don't just stop it reflexively.
Okay, let's touch on atrial fibrillation management in thyrotoxicosis. It's super common.
Extremely common. The main goal, though, is treating the underlying thyrotoxicosis. Often, the AFib is rate-related and will resolve or become much easier to manage once the patient is euthyroid.
So, acutely, it's all about rate control.
Primarily rate control, yes. Beta blockers like propranolol are ideal if tolerated because of the dual benefit. Calcium channel blockers like diltiazem are alternative.
What about anticoagulation? Patient comes in with thyrotoxic AFib, automatic anticoagulation.
No, not automatically based on the thyrotoxicosis alone. This is a key point from AHCC guidelines. The decision for anticoagulation, especially long-term, should be based on the patient's underlying stroke risk using the CAODS VASC score.
So assess their score based on age, heart failure, hypertension, diabetes, prior stroke, etc.
Exactly. Thyrotoxicosis is considered a transient risk factor. If their CHA or VASC score is low, they may not need long-term anticoagulation once euthyroid. If the score is high, they likely need it regardless of the thyroid status. Don't anticoagulate just because of the thyrotoxic AFib itself without considering the underlying risk factors.
Got it. Now, what if the standard therapies, the 4 pillars, aren't working? The patient's still critically ill, maybe even deteriorating. What are the advanced options?
When medical management fails or is contraindicated, maybe severe liver failure precludes thionamides or they had prior granulocytosis, we have to escalate. The main option is plasmapheresis, or therapeutic plasma exchange, TP.
How does that work?
It physically removes thyroid hormones from the blood. T4 and T3 are highly protein-bound, making them good targets for removal by TPE. It can rapidly lower hormone levels, sometimes by 50% or more with one treatment.
So it's a bridge.
Exactly. It buys time, it gets the hormone levels down quickly while other therapies hopefully start to kick in, or it bridges the patient to definitive treatment if needed. It requires intensive care coordination, usually with nephrology or transfusion medicine involved.
And the most definitive but riskiest acute intervention.
Emergent thyroidectomy. Surgical removal of the thyroid gland. This is reserved for life-threatening situations where medical therapy has truly failed or is absolutely contraindicated, and the patient remains unstable.
Major surgery on someone in thyroid storm sounds incredibly risky.
It is extremely high risk. The anesthetic challenges are significant, including risks similar to malignant hyperthermia. It really requires a specialized center with experienced endocrine surgeons and critical care teams comfortable managing these patients perioperatively. But in rare cases, it's the only option left.
Okay, assuming the patient survives the storm and is stabilized, what's the plan for definitive therapy to prevent this from happening again?
This goes back once again to the underlying etiology. For Graves' disease, the options are usually long-term antithyroid drugs, typically methimazole for 12-18 months, hoping for remission, radioactive iodine, RAI, ablation, or surgery, thyroidectomy.
Is long-term methimazole becoming more accepted?
Yes, particularly low-dose maintenance therapy. For patients who relapse after a standard course or who prefer to avoid RAI or surgery, continuing a low dose of methimazole long-term is a reasonable and often safe strategy to maintain euthyroidism.
What about toxic nodules or toxic multinodular goiter?
For those, ATDs like methimazole are just suppressive. They control the symptoms but don't fix the underlying problem. The nodules will just become hyperactive again if the drug is stopped. So definitive therapy is required.
Meaning RAI or surgery?
Right. Radioactive iodine ablation is often preferred as it's less invasive. Surgery is usually reserved for very large goiters causing compressive symptoms, or if malignancy is suspected, or if the patient prefers it, or RAI is contraindicated.
And for those tricky AIT cases?
Depends on the type. Type 2, destructive, usually resolves once the amiodarone effect wears off and the steroids are tapered. Type 1 synthesis often requires definitive therapy eventually, like RAI or surgery, because the underlying autonomy persists. If AIT is severe, refractory to medical therapy, and especially if the cardiac condition is worsening, then urgent thyroidectomy might be considered, despite the high risk.
How do we monitor these patients acutely and long-term?
Acutely, it's intensive monitoring, continuous cardiac telemetry, frequent neurochecks, serial thyroid function tests, TSH, free T4, maybe total T3 initially every 12 to 24 hours until they're clearly improving. Plus watching for signs of other organ failure, lungs, kidneys, liver.
And after discharge, long-term follow-up.
Check thyroid labs, TSH, free T4, every 4 to 6 weeks initially after stabilization, then spread it out to every 3 to 6 months once they're stable and euthyroid on their treatment plan. And crucially, ongoing monitoring for antithyroid drug side effects.
Specifically, agranulocytosis and liver toxicity.
Exactly. Patients need clear counseling on the symptoms of agranulocytosis fever, sore throat, and told to stop the drug and seek immediate medical attention if those occur. Regular liver function tests are also important, especially with PTU, but methimazole can cause issues too.
Let's bring it back to prognosis. What happens if storm is missed or treatment is delayed?
It's grim. As we said, mortality rates can be as high as 25% in some series for full-on storm. Even just uncontrolled chronic thyrotoxicosis significantly increases the risk of serious long-term problems, persistent AFib, high-output heart failure leading to cardiomyopathy, stroke risk.
So prompt recognition and adherence to these guideline-based multimodal therapies really does save lives.
Absolutely. The evidence strongly supports that a structured, rapid, multidisciplinary approach involving endocrinology, cardiology, critical care, and often pharmacy directly improves outcomes and reduces mortality. Speed and precision matter immensely here.
It really drives home the key principles. Recognize storm clinically using tools like BWPS, rapidly differentiate the cause synthesis versus destructive using history, TRAb, and often Doppler ultrasound, and then immediately deploy those 4 pillars: cyanamide, iodide after 1 hour, beta blocker, and steroids.
That coordinated attack is essential. It truly makes the difference between a potentially fatal outcome and recovery.
So as we wrap up, maybe a final thought or challenge for our listeners, something to consider next time they encounter a patient like this.
Okay, here's something to mull over. Given the recent data showing similar mortality between PTU and methimazole in STORM, how does that really change your practice? Are you still defaulting to PTU because of the historical teaching about peripheral conversion? Or are you now more readily choosing methimazole first, especially in patients with any hint of liver issues? Does the theoretical T4 to T3 blockade benefit outweigh the known, albeit rare, risk of severe PTU-induced liver failure in your clinical judgment?
That's a great practical question. And maybe one more.
Sure. Think about the power of rapid bedside diagnostics, specifically POCUS thyroid ultrasound with Doppler. How proactively are you using that tool, especially in suspected AIT cases, to differentiate type 1 high flow from type 2 low flow before committing to potentially unnecessary thionamides or delaying essential steroids? Could leveraging that immediate vascularity information be one of the most impactful ways to accelerate appropriate etiology-specific care and improve outcomes in these complex patients? Consider how faster differentiation enables faster, more precise treatment.